Thank you very much, Dr. Reddy. Can everyone hear me?
Yep, very good.
All right, excellent. So although my title includes PET, I'm actually going to be focusing more on the SPECT side of things. In particular, I'd like to really highlight the advances that we've made in terms of developing SPECT blood flow and the data that we have to support this, all of which was done here in Ottawa under the leadership of Dr. Ruddy. And so I would really like to focus on that side of it today as we move forward. I do have a few disclosures. A lot of this research was done in collaboration with GE Healthcare, and it's their camera that we use to do our flow presentations and so forth. And one of the co-authors of our study I'll talk about later was a GE employee. So most of you already know all of this, but just to set the stage, why do we want to talk about blood flow? We know that perfusion imaging uses a relative evaluation. So we're looking at the heart in comparison to the brightest spot we see, and assuming that that brightest spot is normal. And of course, if that brighter area is in fact disease, then we have an underestimation of both the severity and extent of disease. And depending on the population that we're working with, our referral base, that percentage of people that have a high amount of disease or multi-vessel disease can be up on the order of 20%. And with relative perfusion imaging, PET does a bit better than SPECT, but still misses about 30% of these cases. SPECT, however, misses almost half of them. So there's a lot of patients we're missing. We know, though, that using absolute blood flow can help identify multi-vessel disease. I'm hearing an echo, sorry. Hopefully that's not coming through. Absolute blood flow identifies multi-vessel disease, and this allows us then to identify these cases and move forward. And of course, if we have absolute blood flow, we can also improve our ability to stratify for prognosis above simple ischemia measurements as well. So why, if we have this with PET, do we want to try and get it going with SPECT? Well, if we look at how nuclear medicine is distributed in Canada, or actually across North America, we see that we have a very large percentage of cardiac studies, on the order of 50% or more. And in Canada, we do about 2 million odd nuclear medicine studies or cardiac nuclear medicine studies per year, or about 1 million cardiac studies. But we do the vast majority of these with SPECT. So although PET does a great job, and we've had blood flow with that now for a while, we don't or aren't able to provide that information to a large number of the patients that we're evaluating with this technique. And so we'd be very interested in trying to move this forward with SPECT. And this is something we unfortunately have not been able to do up until a few years ago, I guess now, because in order to do absolute blood flow analysis, you need to be able to measure dynamically. But back in about 2008 or so, new technology was introduced for SPECT imaging, which allowed us to image multiple views around the patient simultaneously, and actually without rotating the camera, so essentially with a stationary camera, acquire SPECT imaging. And this really opened the door to doing dynamic SPECT in a fashion that is straightforward, in that the patient slides in, we don't have to do fancy acquisition protocols and so forth, and patient-friendly. And this then allows us to really explore the possibility of doing SPECT blood flow. Under the leadership of Dr. Ruddy, we were very fortunate to receive the first production model of GE's Discovery CANM-'23 camera at the Heart Institute in April of 2009. And this is one of these cameras that could do dynamic imaging. So we then wanted to test how well this might work for doing flow. We started with basic science studies, looking at a large animal model. In this, we used an LED occlusion during stress and used microspheres injected in simultaneous with the radio tracer in order to provide a gold standard comparison. So can you do dynamic imaging? You can. So this is just some slices, transverse slices pulled out of one of these pig studies where the timing of the different slices is indicated on the top. So a series of 10-second images and then longer images would go down. And we can see that you can visualize the appearance of the tracer in the atria moving forward from the right into the left heart and then accumulating in the myocardium as time progresses. So this looked promising. We then took a look at the dynamic reconstruction and pulled out using region analysis in a similar way to what we do with our PET software, and pulled out blood pool images and time activity curves, and these all looked very nice and very similar to what we were looking for. So, hey, this is great. We may have something that might work. We can do that at rest. We can do that at stress. And here we see the occluded region in the pig's myocardium. And doing that, we can compare then how the estimated kinetic parameter, K1, compares to the measured flow using the microspheres. And what we see is very good correlations, giving us, again, confidence that perhaps we can use this moving forward. So once you have this correlation between the kinetic parameter K1 and the blood flow, you can apply a correction factor in order to generate an actual blood flow measurement. So we explored this in the large animal model with all of the common tracers used for myocardial perfusion imaging in SPECT, and saw similar correlations for all of them, all of which were up on the order of 0.8. So we had something that we thought really might work, but now we need to test it in people. So we're very fortunate at the Heart Institute to have an excellent PET program, and this allowed us then to directly compare measuring myocardial blood flow with SPECT to measuring myocardial blood flow with PET in the same patients. So we undertook this study, and again, now we can move into a human scenario. We can try the dynamic imaging. Similar to the PET acquisitions, we can see that the dynamic images will give us a reasonable series of images over time. And the ROC, or the time activity curves rather, if we compare them between what we got with tetraplasmin in a human patient and what we got in the same patient using rubidium PET, we can see that there's a lot of similarity. The time activity curves with SPECT are a little bit noisier, but the shape is very similar. And when we convert that over into blood flow, we're going to get good correlations. So we first looked at just the kinetic parameter compared to the blood flow as measured by PET now instead of microspheres. And we did this both with and without attenuation. Now, this camera normally does not have a CT attached to it. We went to great lengths to obtain a CT that we co-registered as well. So we're able to compare both with and without attenuation correction, expecting initially that attenuation correction would be something fundamentally necessary to make this technique work. What we saw, however, was that, in fact, it didn't, and we ended up with almost better correlations without attenuation correction. Looking back at the mathematics, we realized that because we're comparing uptake measured in the ventricle of the myocardium to get our input function to uptake in the myocardium itself, those effects of attenuation on average are canceling out. And so our global values actually gave very good correlation with our PET flow values, allowing us to give, once we convert into actual myocardial blood flow, correlation values without attenuation correction almost at 0.9. And with attenuation correction, actually a little bit lower. Now, this isn't true for regional analysis, as we'll see in a second. First, just to show the Bland-Altman plots, you can do this and see that if you look at the relative difference between the PET and SPECT myocardial blood flows, it's reasonably uniform across a range of flow values with a standard deviation of about 30%. So that's the variation between measuring it with PET versus SPECT. Regionally, we don't do quite as well without attenuation correction because, of course, attenuation is heterogeneous. And so our correlation drops, but it's still not too bad even without attenuation correction, giving us correlation values of about 0.8. If you want to move this into the clinic, though, you need to have some idea of the uncertainty when you're measuring this technique in your patients. And so we undertook this as well, looking at both our data where we compare the SPECT information to the PET, and later where we did inter-SPECT comparisons and looked at how much variation there was between users applying this technique. And with the current software that we're using now in our clinic, this is a 40M software out of Ann Arbor, Michigan, we can see that we get uncertainties or variation between users with a standard deviation of between about 15 and 20–25%. And it actually is a little bit better if you use a different model for doing the evaluation. Normally we use a one compartment model, which is what we've been using all the time with PET imaging. If you look at using a retention model, which is a somewhat simpler model, we can actually improve our precision a little bit, and those are the numbers you see on the left. What's most important, though, is our repeatability of our measurement if we do a study one day and then bring the patient back another day and can do the study all over again. So we took a number of patients and did this, where we imaged once with SPECT and then again with SPECT within a few weeks and compared how well these different measurements correlated and compared. And with that, we find without attenuation correction, but with motion correction, we've got standard deviations on the order of about 35%, and again, a little bit better with the retention model. Now, looking at all of this variability or variation was all done using a single center, in our case, our center here. Other centers were also exploring this at the time, but if you looked at the literature and looked at the values that people were coming up with, you saw a wide variety of flow measurements in rest states and stress states from different centers around the world. Now, these are also with different populations using slightly different techniques and different software. So really, we wanted to try and get a handle on how well this technology could be spread out from Ottawa into other centers. In other words, what is the reproducibility of this technique across centers? Because that is also very important for clinical implementation. With that in mind, and GE's assistance, we undertook a multi-center study using a variety of sites around the world, a couple here in Ontario, in Ottawa and London, but also one from Italy, Germany, Japan, and Singapore. With these different sites, we did training using a protocol that was standardized at our center here in Ottawa, and then training with feedback from Ottawa on a small set of patients. And once the approach was normalized, we undertook acquiring data on 25 to 35 patients per site using a standardized protocol, which is briefly described here on the slide, and also took a look at how long patients were inside of the camera room. This gave us some very encouraging results in that the differences between different sites were reasonably small. The bias was under about 5 to 10% in most cases, and the uncertainties were less than about 20%. Correlations were quite high, up to about 0.9 with motion correction. Without motion correction, a little bit worse. Looking at Bland-Altman's, we can take a look at what the uncertainty is in the repeated measurements between evaluation in Ottawa and evaluation at the local site. And we see standard deviations down around 15 to 20% for flow and about 20% for the reserve. These values are much less than our retest repeatability of 35 to 40%, and similar to what we had for our inter-observer variability. So this is very encouraging for generating a consistent measurement of flow amongst multiple sites around the world. However, the time for this did increase substantially. If we look, there is variability around the sites, of course, but if we look at how much it increases between just doing a standard perfusion protocol and doing a flow protocol, we had an average time increase of about 60 minutes. Now, this does include the time for stressing, which in a typical one-day protocol, the stressing is not done in the camera room, and here it has to be, but there is still an increase in time. So we also looked at what we might do to mitigate that problem. So our standard protocol looks something like this, where the dynamic portion is in the cyan and the blue and the green, and static acquisitions are done in orange. But again, learning from our PET imaging, if we could use the latter portion of our dynamic uptake to generate our static images, or what would normally be our clinical images, we might eliminate the delayed static imaging that we typically do with SPECT imaging. And this would allow us then to greatly shorten our protocol and still give us good information. We looked at this using some, if you will, physics measurements of the uptake of the perfusion, just strictly looking at what the relative perfusion is on the images acquired early using the dynamic portion versus delayed imaging. And what we found is that there are statistical differences. In particular, there is increased extracardiac uptake in the early imaging. And this led to interference with values, particularly in the inferior wall, as indicated in the polar map down below. However, a lot of these differences were up in the realm where we would normally call things normal without an impact. And so we needed to assess the clinical relevance. Just to give you a couple examples, this is what you might get without extracardiac interference, but when you get interference, as indicated by the yellow arrow, we can see a decrease in the uptake in the inferior wall that's more marked with the early imaging than it is with delayed imaging. And this happens in around 25% to 30% of our patients. So we wanted to look at this further, and this was done by a fellow under the guidance of Dr. Ruddy. He looked at about 100 patients and evaluated them in a more clinical fashion, looking at some perfusion scores, and found that we had excellent correlation at about 0.9 for some stress and some rest. So this suggests that, yes, it might in fact be possible using clinical evaluation to get a much shorter protocol and still obtain flow information, but of course this still needs a little bit more further evaluation. There are a number of different ways we can use myocardial blood flow imaging. Similar to how we use PET, we can help our evaluation of rest stress perfusion imaging. We can also use it to enhance our confidence for doing stress first imaging. This is just an example of a patient where the rest stress imaging was improved with SPECT myocardial blood flow. It's an 82-year-old female with exertional dyspnea. She had a positive ECG, didn't have any chest pain, did show hemodynamic changes though, indicating we do have a response from our stressing agent, no TID, reasonably normal ejection fractions. There is a mild reduction in the inferolateral wall, as indicated in the yellow arrow, but it seemed to mostly normalize on prone and led to an evaluation of a normal study. However, the flow values you can see are markedly depressed, particularly in the LCX region, and on ICA, we find that this patient did have multivessel disease with the most severe disease located in the circumflex artery. If we look at a meta-analysis of a number of different SPECT studies on myocardial blood flow, we can see that with the addition of blood flow, we get improved sensitivity, or improved specificity rather, with maintenance of sensitivity, suggesting that myocardial blood flow, as we might expect from our PET experience, can lead to improved diagnosis. If we look at stress first imaging, here it can help avoid the use of rest imaging by doing a better job of identifying patients who are normal. So this was a study undertaken by another one of our fellows, Dr. Al-Shaheen, again under the guidance of Dr. Ruddy. He looked at a whole bunch of studies where we did have blood flow information and also had resting data later, and looked at the interpretation as a stress first image without blood flow. And here we found that about 8 out of 31 patients would have qualified for no rest imaging. However, if we add in the flow information, that number increased to 23. So it changed from 26% to 74%. And these patients on rest imaging were identified correctly as normal. So just to summarize and finish up, SPECT blood flow is feasible. We have validated it with large animal models. We have validated it against PET. Other centers have validated against invasive measures like FFR and ICA. It has reasonable inter-observer variability and repeatability from day-to-day repetitions in SPECT and repeat SPECT studies. Multi-center studies show that we can get consistent measurements. However, there is a time increase that's associated with doing this type of protocol. But looking to the future, some modified protocols may allow us to decrease that time further, although we still want to look at that a little bit more. Careful clinical implementation of SPECT myocardial blood flow does have the potential to improve SPECT perfusion imaging. So thank you very much for your attention. I'd like to acknowledge a huge number of other people that have been involved in all of these studies, and in particular, Dr. Ruddy for all of his leadership in pushing this whole program forward. Without him, it would not have been possible. So thank you all for your attention, and I will close with that.